Well, thanks so much, Stephen, for summarizing that. There's quite a bit to unpack here, and these are, again, exciting times for our patients and also medical oncologists. Small cell lung cancer historically has been a hard disease to treat, and we are now finally seeing, as you stated, the overall survival here with a hazard ratio of 0.73. Ticiana, initially when IO was approved in small cell lung cancer, as Stephen said, that we had seen similar hazard ratio, what we are seeing that is in addition to lurbinectedin. This was a maintenance trial, so this overall survival benefit is in addition to what we've seen in the past. Can you please help us in the context for our patients and us as medical oncologists, what should this data mean to us?
Yeah, I think this is, a trial that clearly is showing that there is clinically significant improvement in terms of the outcomes of progression-free survival and overall survival. And I think this is, as you stated, a very difficult to treat disease. And while we had gains from immunotherapy and immunotherapy in combination with chemo and maintenance, that benefit was modest, but also meaningful. And this builds upon that. So again, this is a study that is from randomization. We're calculating the overall survival, so we do have to take into account induction. And so this is a difference that's meaningful. It's definitely a gain. We're seeing here 13.2 months, adding the induction, as Stephen mentioned, add an additional 3.2 months. So certainly I think for our patients who are fit and eligible for chemotherapy at maintenance, I think this is a strategy that offers improved outcomes. Certainly having to balance side effects and quality of life and having that discussion with patients. But I think overall we're very accustomed to managing side effects from lurbinectedin. As previously stated, we've been using it in the second line and beyond. And so we've been accustomed to managing the side effects of lurbinectedin. And importantly, I think here there weren't any sort of synergistic effects in terms of side effects when you added it to immunotherapy. There was an increased risk of immune-mediated adverse events. So again, no signals there in concerns, but certainly having the discussions about managing side effects and being proactive. And certainly I think the growth factor is an important component of managing.
Ticiana, I echo what you said. Any survival here in this disease is meaningful. And we'll switch gears to talking about side effects. But before we do that, Stephen, this data was adapted shortly after its ASCO presentation. And now it's also part of NCCN guidelines. I think it's fair to say that most of our small cell lung cancer patients should receive this. So I think broadly, if you're using it, an important question would be, who is perhaps not the right patient for this approach?
It's a good question. In the study, to be eligible for that randomization, you had to have recovery of hematologic parameters. So you needed to sort of see that CBC come a little closer to normal. You had to have no progression, importantly, and still a good performance status. So I think we'll know them when we see them. Certainly if someone's progressing, we don't talk about maintenance therapy. We talk about second-line treatment, which really would be a different strategy. But if patients still feel well and if the blood counts have recovered, it is something I think we should consider. If patients are still prolonged cytopenias, neutropenia, that hemoglobin just not coming back up, maybe someone with underlying MDS or some poor marrow reserve, this might not be the ideal strategy. If someone is just too frail after therapy, which does occur, this might not be the best strategy. We don't want to do any harm. But if patients are feeling well, which often they are after we get that initial response, then I think it really should be considered and offered.
Absolutely. And again, in second line, we have lurbinectedin as a single agent and also tarlatamab. So if the disease was to progress, we lean into those second line treatment options.